Chapter 4. This is a pretty easy chapter. I'm not going to go into a lot of detail about it. The book does a good job of talking about Chapter 4. And basically, in a nutshell, what it does is compares some foreign countries, some other countries' healthcare systems, and compares it to the U.S. So there's a lot of healthcare data in this one. Again, looking at the per capita expenditure of the U.S. and comparing it per capita to other countries. Obviously, the U.S. is by far the most expensive. We spend the most money on the planet. And then even as a share of our GDP or gross domestic product, again, the U.S. spends by far the most money. These are two measurements that compare apples to apples of how much a country spends on their health care. So for every person, the average cost per person within a country, right? And then GDP, meaning of all goods and services within a country over a given year, this is how much of it was spent on healthcare. So for example, in 2008, $16 out of every $100 in the US was spent on healthcare. And so if you look at that in Japan in 2008, of every $100 in Japan that was spent within their borders, $8 was spent on healthcare. So it's a good way to compare apples to apples of what healthcare spending is across the world. This one is a breakdown and it looks at it by year. So you can see here, the thing to take away is that global healthcare costs are increasing. Okay, it's not just in the U.S. Global healthcare costs are increasing, but the thing of it is in the U.S. is that they're increasing at an unsustainable rate in the United States. Okay, other countries have very different healthcare systems in place, and they can put cost control and cost containment measures in place. You know, governments can do that very easily within these universal healthcare countries, but in the U.S., most of our healthcare is private, and a good bit of it, is not controlled directly by the government. Okay, and there's not really a lot of regulations on that make a big impact anyway on technology and technology disbursements and wasted medical spending. So you can see here is that while globally healthcare costs are increasing, in the U.S. is increasing at a quicker and unsustainable rate. And this one is showing GDP. So that's per capita expenditure over the past 40 years, and this is GDP expenditure over the past 40 years. So again, globally it's increasing, but in the U.S. it's just increasing at a faster rate. This graph is showing of all the countries, right? The blue is public healthcare expenses and the orange is private healthcare expenses. So in the US, this is as a share of our GDP, right? About 7.5% of our healthcare is spent from the public sector, meaning private health insurance, and then 8.5% is spent from the 7.4% spent from the public sector, meaning Medicare, Medicaid, okay, in SCHIP or the state Children's Health Insurance Program and other government programs, and then 8.5% is from the public sector, the private sector, meaning private health insurance, group health insurance at work, right, employer-sponsored insurance programs, and that's by far the largest percentage than any other country on the planet. See, we're right on point with public healthcare spending, but when you look at it, when you look at this graph right here, okay, this is everybody that has access to health insurance through public coverage. And if you look at all these countries right here, it's 100%. Everybody in these countries are covered 100% by public health care. Okay. In the U.S., it's about 27% of our population is covered by public health care. 60% almost is covered by private health insurance, and then we have a nice chunk of uninsured. Okay, there's 3 countries that are not near universal coverage, and that's Turkey, Mexico, and the United States. Every other country on the planet has universal health care, and I believe Turkey, because of wartime and war-torn, is why they have pretty high uninsured. I'm not positive on that, but I think that's what it was from, if I remember correctly. And then Mexico, um, because they don't have a lot of money. So if we go back to this one right here, so again, when you look at this, while the United States is right on point with public health care expenses, that does not cover all of our entire population. Versus in Germany, they're spending 8.1% of their gross domestic product on public health insurance, but that covers 100% of the population. We are spending 7.4% of our dollars within our country, right? 7.4% of our GDP on public health care, and that covers a quarter of our population. Okay, huge difference. OECD, that's the organization for economic. Oh, what does that stand for? It's basically it's the Organization for Economic Cooperation and Development. That's what it is. It's an organization of countries that they get together and they try to put policies in place to be able to stimulate the economies of countries across the world, global economy. Okay, and so these countries right here, I picked out 5, 1, 2, 3, 4, 5, to compare their healthcare costs to one another. And if you look at yellow and green, this is public dollars that are spent towards healthcare. Okay, of national health spending by source. Okay, 2007. So if you look at the U.S. compared to these other countries, about 45% of our healthcare costs come from the public sector, versus this right here, 37, about 40% of our healthcare costs are being spent from private insurance. And that is by far the largest margin of any country on the planet. And again, the biggest thing to take away from this is that look at these countries here: France, Germany, Canada, Japan. These healthcare costs cover 100% of the population, right? Canada spends 71% of their healthcare costs as a country from public dollars, but that 71% covers everybody. And then you can get supplemental insurance if you want, private insurance, if you wanted to get something that maybe the private or maybe the government doesn't cover. Okay, if you wanted to get some sort of, if you had money and you wanted to get some extra coverage to be able to pay for some more exotic tests, CT scans, or if maybe you have cancer and you want to get some, and you have some money to spend and you want to buy a supplemental private insurance plan so that you can get some high dollar cancer treatment covered. Okay, that's what that is right there. This is more supplemental. So this right here in the private market covers 100% of the people within their borders, versus ours, it doesn't. Okay. That's the big takeaway, is that access, even though we have high costs, not everybody in the country is covered. And so with all the money that we spend, typically, in our economy, in the U.S. economy, we are bred to think that the more money you spend on goods and services, the higher quality the good and service is, right? If you look at purchasing a car, if you spend $8,000 on a car and that's your budget, well, then you're probably going to get something used, which is fine, but it's going to be used and it's not going to have all the bells and whistles, most likely. You won't have leather interior. It's not going to be a Mercedes-Benz. Versus if you have $85,000 to spend on a car, you're going to get something that's of better quality. It's going to be a luxury automobile. Maybe it's going to be something bigger. It's going to be something that's a better automobile. Not the case with the healthcare system. We spend by far the most money on the planet, and so you would think that with the $3 trillion that we spend, that hey, everybody gets healthcare in the United States and everybody gets good healthcare in the United States. That's not the case. And so what this graph right here shows is that it shows quality indicators within our borders. So for example, with all the money that we spend in the U.S., we still have a 75.4 years of life expectancy, which I think is good for right about 50th on the planet. Of all the countries, I think that ranks 50th. And I think I think Japan was number one with like, I think they got up into 79 or 80, and they spend half, I think less than half, on their healthcare system than what we spend in the United States. Okay, 75.4 for men, and then in Japan, I think for a female it was like 82, something like that. Maybe it was higher. Okay, and then this is a big one right here. Infant mortality, or deaths per live birth. Okay, how many stillborns are born in the U.S. every year? 6.7%. 6.7 out of every 1,000 births in the U.S. every year, or sorry, in 2007, almost 7 of them were stillborn. And you look at other developed nations, it's much less than that. Okay, I think ours was on point with some third world countries almost. Okay, and other very, very far down on the list where we were ranked globally. There's a good, you can look that up online to see if you wanted to see. Actually, you know what? There's the link that I have of global health stats and other health stats on the in Blackboard. Okay, and you can feel free to go to Blackboard and look under courses, course documents, and other resources. And there's a link on there if you want to look up on a global scale of where we actually rank. So the thing to take away is that even though we're spending an obscene amount of money, okay, life expectancy is not any better in the U.S. and live births to deaths, or infant mortality, if you will, is not any better in the U.S. when you look at it from a global ranking. And the thing to take away from this as well is it's for what pulls life expectancy down is chronic disease and a care disparity, meaning that when you have Medicaid and maybe a very low level HMO insurance, the quality of care you get is not as good as if you have a very good Medicare insurance, or if you have, better yet, a private health insurance PPO plan. Okay, or if you have money. If you have money, you get the health care that you need in the U.S. And if you don't have money, good luck to you. This right here is a graph that shows overutilization of healthcare in the U.S. And so if you compare what we do in the U.S. compared to some other countries, I mean, we are by far using much more healthcare services and much higher dollared healthcare services. Okay. How many CT scans per 1,000 people in the U.S. in 2007? We have 228 CT scans per 1,000 people in the U.S. I mean, if you look at this, 45 in France. In the UK, 59. There's too many CT machines, too many MRI machines, and we are overutilizing them, which is taking the cost of the healthcare system and moving and skyrocketing it. Okay, there is no incentive in place for a physician to not overutilize, because again, it all comes back to the fee-for-service model. The more services you do on a patient, the more fees you get reimbursed. Okay, there are no incentives in place for a physician to be able to deliver quality health care or to take somebody who's sick and get them well. Okay, the incentive is to treat, and the more you treat, the more money you have coming in, because it's a for-profit system for the most part. And that's not the case in some of the other countries, which we're going to get into in a minute. Okay. And before we get into some other characteristics of some global healthcare systems, this just looks at chronic disease in the U.S. and compared to other countries. And if you look at Mexico, just overtook the U.S. with chronic disease prevalence. Right, this looks at diabetes right here, and if you've seen anything or done any, if you've seen anything in the news recently when it talks about Mexico and chronic disease, they blame the United States for their high chronic disease, with all the fast food companies that have moved from the U.S. and have grown into Mexico, Kentucky Fried Chicken, McDonald's, Burger King, Wendy's, stuff like that. Is that now that is cheap food that is now moving into Mexico and causing their diabetes rates to go up, as well as a lot of soda, Coca-Cola, Pepsi, and whatnot, moving into the U.S. because I guess moving into Mexico. That's very popular in Mexico because it's inexpensive and not a lot of people have a lot of money. another chronic disease chart. This right here is just further evidence of a quality of care disparity in the U.S. as compared to some other countries. And so what this says is low-income populations more often report unmet care needs due to the cost of care. Why does that keep moving? Okay, there's still variations across other countries, but in the U.S. it's much larger variation. Okay, meaning that below average income, if you have a below average income in the United States, odds are you're not getting your care needs met. 52% of people in the United States that are deemed to be below average income, 52% of them feel they're not getting the their healthcare needs met. Okay, either because their HMOs or managed care within Medicaid is not paying for some of the things that they need, or because they just don't have the money to pay for it out of pocket themselves, or both. Okay. So what we're going to look at now is 3 different models of national health insurance that have different characteristics, and then we're going to compare it to, again, the private health insurance market, which is really it's dominated in the U.S. This is the model that we have in the U.S. Okay, it's a patchwork quilt. We have some characteristics of some of these other models, but at the end of the day, there's just so many healthcare systems in place in the U.S., especially when it comes to private health insurance. So let's look at these models real quick. So the first one of a foreign healthcare model is called the Bismarck model. Again, you can read up on that right here, and you can also go in the textbook. The characteristic of a Bismarck model in Germany and Japan, is that the government mandates that the entire system is nonprofit. First of all, okay, hospitals and physicians are all private practice for the most part. Okay, they're mostly private practice, meaning that they work for themselves. Okay, like what they do in the U.S. Okay, there's a Baptist Health or St. Vincent's or the Mayo Clinic. You have a Dr. Whoever who has his own small primary care practice. You have the Jacksonville Orthopedic Institute, which is a group of orthopedic physicians that started their own practice. Okay, those are private hospitals and private physician practices. Same thing in the Bismarck model is that there's private hospitals and private physician practices. But the thing that's different is that the government has control over the entire healthcare system, and the government controls and sets rates and caps reimbursement rates. So in the U.S., doctors and hospitals and physicians, they can set their own rates of what they want to charge. And that's why there's a big disparity. So if you get a primary care physical in Florida, it's going to cost different here. Let's say that maybe it costs $100 versus a primary care physician in New York City and Manhattan can charge $300 if they want to, versus somebody in California can charge $250 if they want to, right? And so doctors can charge different rates for their services. In the Bismarck model, the government sets that. Okay, so that there is continuity across the entire country of what it's going to cost to get a primary care physical, and that's not going to differ between states. Okay, in the Bismarck model, and so the government has a lot of control. While the whole system might be private, okay, the government sets what the rates are going to be, and sets who's going to get paid what at what rate, and also mandates that the entire system is nonprofit. And so, insurance companies cannot make a profit. They have to reinvest all their profits back into their insurance funds. Okay, so the Bismarck model would be what we have in the United States if the government had a lot more control and a lot more autonomy over it. Okay, if the government could set reimbursement rates so that the entire country, so that it did not differ from state to state, and the government mandated that instead of Blue Cross and Blue Shield making a 15% profit margin and that money going to stakeholders, what they would have to do is take that money and reinvest it back into the healthcare system so that you keep costs down, and so that citizens aren't paying for all the price hikes. Okay. Some more characteristics of the Bismarck model. You can go in there and read that yourself. In a nutshell, it's successful and it works. It keeps costs down. quality of care. There's not a big quality of care disparity between different socioeconomic groups. Okay, and on the at the World Health Organization, people that work at the World Health Organization are usually people from countries that have the Bismarck model. Okay, the second model is the Beveridge model. Now, and if you see down here, this is the one that sort of Great Britain, Spain, most of the Scandinavian countries. In the Scandinavian countries, they're the healthiest. Okay, considered to be the healthiest. Those are some of the best healthcare systems on the planet. And so what this one does is that this is a public system. Okay, the government is the main supplier and the only payer of healthcare in the entire country. Okay, when you hear, sorry, let me go back. The Bismarck model is financed through employers and an employment tax. So employers pay a Bismarck healthcare or a sickness fund tax, and employees are also taxed. And so the Bismarck model is funded through taxpayers through a employment tax. Okay, right out of their paychecks. The Beveridge model is taxed through other government taxes, maybe through a payroll tax, maybe through property tax and other forms of taxes. Okay, sort of like how in the U.S. how we pay for public entities such as your police, firefighter, public libraries, public schools. Okay, recently in the news over the past couple of years, whenever you hear Obamacare and socialized medicine. Obama wants to turn everything into a socialized medicine system. This is what they're talking about, the Beveridge model, because this is really a socialized type of a system. Most, not all, but most hospitals and doctors and healthcare providers in the Beveridge model work for the government. It's a government hospital, they're a government physician. Not all of them, some of them can be private, but most all of them within a Beveridge model country work for the government. Okay, the government is the only payer, right? In the U.S., we have the government that pays Medicare and Medicaid services, and then we have all of these 250 different private health insurance companies that pay for private health care, versus in the Beveridge model companies, the government is the only payer. The government sets the rates, the government controls what doctors can do and what they can charge, and the government is the only payer. Big advantage to keeping the cost of the system down. And then obviously at the end of the year, the government doesn't turn a profit. They take all the funds and that money that are invested into the healthcare system, and if there is any leftover money or profit, it's just reinvested back into the healthcare system. Okay, keeps costs down. And for the most part, and you can read this in the text, for the most part, people that live in these countries are happy with the healthcare that we receive. There may be some long lines and longer waits. So whereas in the U.S., if you need to get in to see, if you have a PPO and you want to see a cardiologist, you can call up and probably get an appointment within a week or two, versus in the Beveridge model, because the government controls access and controls how many doctors are practicing within the population. You may have a longer wait. Maybe it'll take a month to get in to see somebody. Okay, but there are cases to where they can rush to get somebody in to see a doctor sooner if it was an emergency, or if they're in need quicker than somebody who just needed a checkup. Okay. National health insurance models. This is like Canada and then some of the Far East countries, Korea, Taiwan. Now, what they have here in the national health insurance models, that they take aspects of both the Beveridge and the Bismarck model. So, for example, the government is the single payer, right? The government sets rates. There may be, excuse me, there may be private providers and there may be public providers. Okay, the single payer tends to have a considerable market power to negotiate lower prices. So if the government was the only purchaser or the only payer for healthcare within the country, then the government can then go to private insurers and the private physicians and hospitals, and they can negotiate lower rates. Okay, versus in the U.S., there's competition. So Blue Cross and Blue Shield and Aetna and WellPoint, all these private insurers can negotiate rates and with a hospital or with a physician's office, and the hospital and physician really has power. Okay, because there's competition out there for their business. Versus the national health insurance model flips it. The government is the only payer. Okay, while doctors and physicians are mostly private, meaning they can go into practice for their own, the government is the only payer of healthcare services. So on behalf of the population, the government can go in, negotiate lower rates, right, to keep cost of the system down. Right, the government dictates who can get what, who gets what medical services, and what the government will pay and what they will not pay. And everybody within that country has access to national health insurance. Now, you can supplement that with private health insurance if you want to. Like if you live in Canada, you have national health insurance. Okay. Because you live there, you are a Canadian citizen. But if you have money, or if you work for an employer that offers private health insurance, you can get double coverage, okay, and sort of use one as a primary and one as a supplemental plan, so that you can get other services that maybe are not covered from the national health insurance plan. Or if you just have money, you just pay out of pocket. But in these countries, you know, there's one health insurance, and everybody within those borders in Canada has access to the national health insurance model. What we have here is a very fragmented model. Okay, so we have different pieces to the puzzle of our healthcare system. So, for example, how the U.S. takes care of its veterans in the VA system. Okay, it's sort of similarly with the Bismarck model. Okay, how the U.S. takes care of Medicare and Medicaid. Okay, it's kind of like the Beveridge model. Okay, then the United States has a very large private insurance market that covers about 60% of the people that live within our borders. That is almost a $1 trillion industry. Okay, but there's so many payers out there, meaning there's so many private health insurance companies that it doesn't necessarily drive the cost down. There is competition to drive costs down, but if it was a single payer, meaning like the national health insurance model, the cost of healthcare would be much lower than it is today. And the book does a pretty good job of discussing and comparing the private health insurance market to Beveridge and the national health insurance model. But we have in the U.S., we have pieces and elements of all of them. Mostly Medicare, Medicaid, right? That's our private insurance. That's our public insurance. And then we have private insurance, which is mostly through your job or employers. Right? And we spent so much money on those two systems, but there's still 17% of the United States that does not have health insurance, that does not have access to affordable health care. Okay, and so what we're going to talk about after this this chapter is the Affordable Care Act, and how the Affordable Care Act tries to come in and tries to slow down the cost of the healthcare system, right? Tries to increase access to the healthcare system and make it more affordable to that 70% that either can't afford it or just doesn't have access to it, okay? And it tries to improve quality of the healthcare system as well, because there's a big quality disparity between Medicaid patients and private health insurance, okay? And there's plenty of research and literature out there to show why that is. And so the Affordable Care Act tries to improve quality of care for Medicaid patients. Any questions, email me. Again, it's a very easy chapter. Give it a read, and hopefully if there's any questions, then we'll email them to me and we'll talk about it in class.